So I'll be because VT itself is a big topic, and I've tried to only discuss or talk about the recommendations from different guidelines. These recommendations will help us in making some clinical decision making when we are managing the cases of VTE. Yeah. So annual incidence of DVT is around 50 to 100 per 100,000 patients, and incidence of DVT before age of 45 years is more in females, and but after age of 45 years, males have more incidence as compared to females, and American Africans have more incidence as compared to Caucasians, and in incidence of VT is relatively more in winter season as compared to summer season. And one of the reasons for winter season is because during winter seasons, the people are more inside and there's decreased mobility and plus decreased water intake. So this is one of the presumed reasons. And similar things are happening in Ramadan also. When you're talking of Ramadan, the mobility is generally reduced and water intake is reduced. So some element of dehydration is there. Also, there's no statistically significant difference in between the incidences. But these are the proposed mechanism by which there may be increased VT events and especially the DVT in during Ramadan. Now, 5 to 10% in hospital mortality is related to the pulmonary embolism, and asymptomatic P is quite common, and it may be presenting as a sudden death. And within 10% of the symptomatic P are fatal within 1 hour. And by 3 months, 15% of the patients have proximal DVT and 70% of patients with P will have died. Okay? And in fact, the in-hospital case mortality is 12%, but nowadays, because of the improving management and early diagnosis, the mortality is relatively reduced, less than 12% generally. But of course, the mortality is much more higher with PE as compared to the DVT. Now, the consequences of VT, we all know there are the five major things we have to remember. Post-thrombotic syndrome is very, very important. Around 15 to 50% of the patients will have these things within 1 to 2 years of the symptoms. And then right ventricular dysfunction, of course, it may be asymptomatic in 50% of the patients. It can be only demonstrated or confirmed by the ECG findings. Chronic thromboembolic pulmonary hypertension, and this is in fact underdiagnosed entity, and it can occur in up to, although if incidence is much less than the other complications, but it is one of the very important cause of pulmonary hypertension as a long-term sequelae. And of course, because of these three major complications, the quality of life is affected, not because of the symptoms, but also overall because of the chances of recurrence of some of these events. And of course, when we have got these complications, it is associated with increased burden as well as the health resources are confirmed. Now, another important thing which of VT is that once you have got a one VT event, there is always a chance of recurrence of VT. And in fact, the recurrence of VT, especially in the first year of the index event, is around 10%. And so within 2 years, around 16% of the patient may have chances of recurrent VT events. And this risk persists for many, many years, at least for 10 years. And by the end of around 10 years, around 1/3 of your patients will have one of the major VT events, which may be DVT or a pulmonary embolism. So this is another important thing. That's the reason some of these patients may have to require a long-term management for VT. Now, we all know as a pathogenic mechanism, varicose triad, these are three basic components we have to remember. The hypercoagulability, which, as I mentioned, dehydration may be one of the contributing state, and then hypercoagulative state, and then we have one including like major surgery, malignancies, pregnancies. We all know, just to remind ourselves. Then another important thing is the circulatory stasis. Of course, again, sedentary lifestyle, immobilization during the hospital, post-operative period. So these are the very known factors, including the dehydration, and especially again we are talking of Ramadan, so it may be one of the predisposing factors. And the third pathogenic mechanism we all know is the vascular damage or endothelial damage to the blood vessels, like cellulitis, thrombosis, atherosclerosis, venipunctures. So these are all three basic pathogenic mechanisms. But when it comes to the clinical markers, nowadays we are highlighting the clinical risk factors or provoking risk factors according to their duration. So what we divide them is in the risk factors have to be divided into a transient and a persistence. When you talk about transient risk factors, especially the major transient major risk factors, and then we are talking of the transient minor risk factors. When you talk about the transient major risk factors like surgery, any surgery which requires a general anesthesia of more than 30 minutes, and if this patient is confined to the hospital for more than 3 days with acute medical illness or any other reasons, that is considered to be a major transient risk factors. But what about the minor transient risk factors? We are talking of the people who are taking hormonal therapy, especially the ladies with hormonal replacement therapy. Pregnancy itself is a minor transient risk factor, pyramid stage, and any confinement to the hospital, more than 3 days, as I mentioned, of course, and then reduced mobility due to the post trauma, post fracture. These are the things. Then we've got a list of persistent risk factors. Now, like active cancer, people who are under treatment for the cancers, in chronic inflammatory conditions like inflammatory bowel disease, rheumatoid arthritis, autoimmune diseases, antiphospholipid syndromes, chronic infections, chronic immobilities, spinal cord injuries. So these are very clinically important risk factors because that will decide the longevity and the requirement for a long-term management for these patients with DVT. So goals of the treatment, when you are confronted with the goals of treatment, first, of course, the major goal is to prevent the fatal PE. And then second goal is to prevent and reduce the morbidity associated with any acute lung DVT or PE. The third thing is the prevention of the long-term sequelae, as I mentioned in my previous slides. Then, of course, prevention of the symptomatic recurrence is another important factors, goal. And then, of course, when you're prescribing the anticoagulation to these patients, the goal is to minimize the risk of bleeding and other side effects associated with the anticoagulant treatment. Now, let us come to the guidelines now. Now, all the guidelines, they are consensus now that drugs are preferred over the VK, the vitamin K antagonists. Now, because of the reasons, although the mortality, not much difference in mortality, and perhaps their efficacy is also equivalent to the warfarin, which has been used for many, many decades. Although there is slightly advantage in people being treated with the DVT, but however, the major problem with this thing is that the incidence of bleeding events is much less common with the DOACs as compared to warfarin. So these are the reasons. So DOACs are being preferred as a first-line management in most of the clinical conditions. Now, all three major guidelines, including the American Society of Hematology, American College of Chest Physicians, European Society of Cardiology, they are in general agreement that the drugs have to be preferred over the VK. Again, because of the reason is this, because less patient burden, no need for frequent dosage monitoring or requiring the blood test, which is essential for the monitoring of the warfarin patients. Then similar efficacy and similar mortality, as I mentioned, and low risk of major bleeding. However, these guidelines, they do not prefer or recommend any preference over a particular drugs. You have got 3 drugs available, 4 agents are available here, and they do not recommend any preference for any particular things. But however, when you are deciding to choose which one to use, you have to consider the other pharmacokinetics and pharmacodynamics of these the conditions, like that renal functions, concomitant therapies, presence of the cancer and drugs, the interaction. So these are the things which need to be considered. Now, the treatment timeline, again, we have to be very sure after the initial management of the maybe 5 to 7 days of with some of the requirements of what we call as a hyperacute phase, when some of the patients may be required heparin therapy or even the direct drugs. Then the primary treatment period is 3 months, 3 to 6 months. And then depending upon the presence of the risk factors, the treatment has to be extended for 6 months or even beyond the 6 months, even sometimes lifelong. So the recommendation is that if there's a transient risk factors, which I mentioned in my previous slides, that you have to discontinue the anticoagulation after primary treatment of 3 months, 3 to 6 months. But if the risk factors are persistent, then perhaps you have to consider it for a lifelong indefinite treatment. Unprovoked VT, again, you need to continue indefinitely. And however, when you are trying to continue the medications for a long time, you have to also consider the risk of major bleeding also as well, repeatedly at different stages of the management. Now, this is the things which we all know. I mean, I don't have to tell all you the things, but what I want to tell is there's a period of initial treatment and there's a period of a long-term management. And sometimes the long-term management, you may have to adjust the dosages when you're talking of extended treatment. Now, let us come to the DVT itself. Now, what is the guidelines? Now, in DVT, you all know there's a clinical clear signs and symptoms are there. If, however, if the clinical signs of DVT are not there, then if you suspect DVT, then you need to have a pre-test probability. Now, this is recommended pre-test probability. Of the pretest probability, we go for the Wells scoring for these things, and if the pretest probability is more than 3, then there are 50% chances that your patient may have a DVT. On the other hand, if you are talking about an upper extremity DVT, we have got a constant score for this extremity, upper extremity DVT. So this is a clinical predictability is very, very important. And what are the guidelines suggest? Okay, first, if you think there's a probability, then perhaps go ultrasound is the first modality of the treatment. And when you ask about the ultrasound, please ask for the whole leg ultrasound, because sometimes the proximal DVT may be in the femorals and cuff may not be there. Okay, so in that way. And the one of the recommendation is that, however, if your patient has got low pretest probability and ultrasound is normal and patient is no other sign of DVT, then perhaps you can not treat that patient and let the ultrasound be repeated after 1 week or 5 days. Okay, this recommendation. However, on the other hand, if you think that ultrasound assessment is inconclusive and the patient has got a high test probability, then you have to go for a diagnostic test, which are the computerized venogram or a computerized tomography venography, or a conventional venography, or even MRV or magnetic resonance venograph may be done. Okay. And the other question sometimes we ask is, what is the role and where is the role of the thrombophlebitis screening? Now, the guidelines recommend that if it is a provoked DVT, there's no need for thrombophlebitis screening. Okay. On the other hand, if there's an unprovoked DVT, then again routine thrombophilia may not be recommended. Okay, except if you are deciding to let us say if the patient has got a family history or a strong family history, especially in the first generation relative, then you need to do the thrombophilia testing. There's another time when you need to do thrombophilia testing is when you're deciding to stop the treatment. So maybe after 3 to 6 months, then perhaps if you think you can go for a screening test, but not at the time of the diagnosis. So these are the recommendations for thrombophilia screening. Now, as far as the management is where to treat now, the increasing trend is that a lot of these patients are being treated at home. If the facilities are available, the guidelines recommend that if there is a deep vein thrombosis and patient has got no limb-threatening ischemia. I mean, sometimes if there's a major DVT, there may be secondary ischemia, compression of the arteries. So if there's no limb-threatening ischemia is there, or there's no risk of bleeding, then the guidelines suggest patients can be treated at home. Okay. Now, the only difference is perhaps, because if those patients who are treated at home, they may have actually fewer side effects and the things. On the other hand, if what about the role of a thrombolysis? Now, the guidelines tells that the anticoagulation therapy alone is enough for most of the cases. Okay, because if you treat this patient with thrombolytic therapy and then anticoagulation, the chances are that okay, you may prevent some of the post-thrombotic syndromes. But then there are more chances of bleeding 31 as you compare between these things. So therefore, the guidelines suggest that anticoagulation alone for DVT is important, except I mentioned if there's any limb-threatening ischemia is there, then you can go for thrombolysis followed by the anticoagulation. Another guidelines about the filter. Now, another things, what is the role? Again, the guidelines recommend the IVC filter is not routinely recommended unless there is a contraindication to anticoagulation. Again, this is very, very important. Both these guidelines, American Society of Hematology and the European Society, they both recommend that intervena cava is not required, except only thing is that when, as I mentioned, anticoagulation is contraindicated, then you can go for a temporary, I'm talking of a temporary inferior vena cava infiltrate session is recommended. Okay, and however, if you are using the IVC filter, it has to be temporary and retractable, so that because it is easy, sometimes it may require another procedure to remove it. Okay, so okay. And what about the use of compression stockings? Now again, this is a debatable things. However, stockings may be considered for a very symptomatic, because it may reduce the incidence of post-thrombotic syndrome. But again, the guidelines, they do not recommend a routine use of compression stockings for the management of anticoagulation alone. Now, one advantage is that the use of compression stockings may improve or may decrease the chances of post-thrombotic syndrome. That is one of the only advantage. But again, you have to individualize your treatment. But per se, it is not any standard care for these patients. And what about the duration? Now, if for a provoked proximal DVT, 3 months treatment is recommended. Only 3 months treatment for DVT. However, if the patient has got a, and the one more thing sometimes we clinician miss is that even once you finish the treatment course, it is better to do the ultrasound. Now, this ultrasound will help to have a baseline assessment, because some of these patients may come to you again for a post-thrombotic syndrome or other problems, and then you may be confusing whether it is the residual thrombus from the previous side or the new one. So this is another thing which you need to be following. Another thing is what about the risk of bleeding? Again, when you are recommending treatment, when you are thinking to increase the treatment for more than 3 months, please reassess the patient after 3 months whether there's any new risk of bleeding or not. Okay. And what about the treatment of unprovoked DVT? Beyond 6 months. Again, beyond 6 months, sometimes you may think of reducing the dose of anticoagulation. For example, if you are using rivaroxaban from 15 to, you can make it 10 also, like this. From 20 to 10 milligram. Similarly, you reduce the dose. I'm talking of extended treatment beyond 6 months. On the other hand, if your patient develops a new event and he's on fully compliant medications, what is the recommendation? The recommendation is to either you increase the dose or you change the agent, one of the DOAX agent, you have to change it. So this is a recommendation if the patient develops new DVT. And what about the deep vein thrombosis of iliofemoral? Now, if there's an iliofemoral deep vein thrombosis, then you need to require thrombectomy or thrombolysis. Okay, it's important here. Only on iliofemoral. But if it is a femoral DVT or popliteal DVT, no need for mechanical thrombectomy. Only for iliofemoral. On the other hand, if the patient has got a CKD, again, you need to repeatedly monitor the kidney profile as well as because these patients are at increased risk of bleeding, so we have to monitor the anticoagulation and monitor the kidney parameters as well. What about the superficial vein thrombosis? Now, superficial vein thrombosis, now this is important, ultrasound dependent management is required. Here, if the superficial vein thrombosis is less than 5 centimeter in length, okay, and there are no other features of risk factors like malignancy, thrombophilia, then a anticoagulation is not recommended for a small superficial vein thrombosis. On the other hand, if superficial thrombosis is more than 3 centimeter away from the junction of superficial with the deep veins, okay, or it is more than 5 centimeter in length, then you can use the smaller doses of the anticoagulation like fundoprenix. On the other hand, if superficial vein thrombosis is more than 5 centimeter and it is more than 3 centimeter away from the junction of from the superficial veins with the deep veins, then perhaps only smaller duration of 45 days duration of the treatment is required for DVT. Now, what about the pulmonary embolism? Okay, I'll try. Again, similarly, if you are thinking of pulmonary embolism, there is a clinical probability score is there. We use the revised Geneva score or Wells score for pulmonary embolism there. And if the score is more than 6 in Wells or more than 11 in Geneva score, then there is a high probability of DVT of P is there more than 50%. Okay, and then for these role of D dimer is not for the diagnosis; it is for the exclusion. Okay. So therefore, alone D dimer is not required for a diagnosis, but you can have a, now when you have a suspected Wells score is high, then either you go for the non-diagnostic VQ scan or you can go for this one CTP. So what is the difference? Now, if your patient has got a, for example, contraindication for the exposure like kidney failure is there, patient is pregnant, or a female previous history of malignancy is there, then you can go for the VQ scan again. And on the other hand, if the patient has a previous lung disease or if you are suspecting any malignancy, other things, then VCTPA is related with the gold standard for these patients. Okay. And related to the symptoms, we all know the symptoms, but I want to highlight here the syncope. Now, around 20% of the patients, syncope may be the only feature of a massive pulmonary embolism. So you have to keep in mind. Now, we have got a PACE score, there is pulmonary embolism severity index for the requirement of the management and where these patients have to be treated. But then we've got a simplified PACE score as well. Okay. What are the recommendation is that if the patient has got no risk factors, no underlying diseases, patient is hemodynamically stable, you can treat the patient at home. Okay, this is a new guidance. You can treat the patient at home, of course. On the other hand, what is the role of thrombolysis? Now, role of thrombolysis is like in those patients, for example, if the patient is have no, I mean, although there's maybe you do the echocardiogram, okay, and do the biomarkers. And although these biomarkers suggest right ventricular dysfunction, but no hemodynamic instability is there, that is called means clinically submissive P, then anticoagulation alone is okay. So a moderate pulmonary embolism with, although there may be element of ventricular dysfunction, but no hemodynamic instability. What is hemodynamic instability? We are talking of a hypotension of less than 90 or a more than 40 drop in the baseline symptoms, then anticoagulation alone is okay. Only thrombolysis is reasonable only for those patients who have got at low risk of bleeding, okay. And the what about the recommendation? Again, you can see the guidelines suggest that even if you are suspecting the P, you have to start the treatment before waiting for the confirmation signing. So this is another important thing. Do not delay the anticoagulation bolus for waiting for the confirmation. And systemic thrombolytic therapy is recommended only for high risk patients. Okay, high risk patient. And what about the embolectomy? Now, surgical embolectomy is recommended when patient is a high risk PE and where thrombolysis is contraindicated. So if thrombolysis is contraindicated, you can go for the mechanical thrombectomy also. Other than percutaneous catheter directed treatment should be considered for patients with high risk PE in whom thrombolysis is contraindicated. Or if your thrombolysis fails and patient remains hemodynamically unstable, then you can go for the mechanical thrombectomy as well. What about the role of norepinephrine and dobutamine can be considered if the patient is high risk, Of course, ECMO is a new mode of treatment. Sometimes patient having massive pulmonary embolism with hemodynamic instability, ECMO can save the lives, okay. And the other thing, this is more or less same, I will say, the role of rescue, what's called a rescue thrombolytic therapy. When you have started the patient on anticoagulation, patient remains hemodynamic and stable, is not improving, then you can go for a thrombolysis even after the start of the anticoagulation. And what about the secondary prevention? Okay, again, more or less is the same, the panel suggests standard doses as compared to the low doses. But if the patient has got a high bleeding risk and you are increasing for more than 6 months or more than 12 months of treatment, then you can use the smaller doses of the dose as compared to the standard treatment. What about the role of aspirin? Now, this is again clinical question. Now, if your patient has got you are starting the anticoagulation, including dose, and patient is clinically stable, long-term IHD, you can stop the aspirin. On the other hand, if the patient has got a recent coronary event, or an active coronary intervention has been done, then you can continue the aspirin. So chronic stable ischemic heart disease, patient on the aspirin, you can stop aspirin and you can start drugs. I think that is the only thing, because I have to finish the time. No, I finished the time. Okay. So I think, thank you. Sorry, I have to hurry up the things, but anyhow, we can answer the question if you want.
Thank you, Dr. Niaz.